Hi friends, good morning. Welcome to yet another session of Dr. Sahasramam's ECG quiz. This is the third of the quiz which we have been discussing. I hope you have been enjoying this series of quizzes and are able to correctly interpret the ECGs which I am showing you. I would suggest that you should always update yourself with your previous ECG classes so that these quiz programs become more effective. Now today I have lined up 3 ECGs for you. There is one ECG on arrhythmia and there are two 12-lead ECGs. So let us get ready with the pen and paper and start the quiz. Now this is the ECG of a 25-year-old female, which was sent to be one of my consultants, Dr. Priya from the Department of Nephrology in the Baby Memorial Hospital. This patient had come to the hospital for a routine checkup. ECG was taken as she was complaining of dyspnea and some palpitations and also some muscle weakness. Now the question here which I would pose to you is, 1. What is the diagnosis in this 12-lead ECG? And 2. What will you do for the patient as an emergency measure? So on with the diagnosis. I'll give you about 2 minutes for this. So friends, we'll go on to the answers to this quiz. What are the findings? I'm sure you would have interpreted this. One, if you look carefully here, you can see a prolongation of the PR interval, right? It is about 7 millimeters, which works out to 280 milliseconds. The heart rate calculated from below is around 100 beats per minute. Now, if you look at the QRS complexes very carefully, you can see the QRS complexes are show a generalized widening. They are widened like this, as if they are pulled out like this, right? But it doesn't conform to the pattern either of a left bundle branch block or a right bundle branch block. Now look at the T waves in the precordial leads here, isn't it? The T waves in the precordial lead show the tented peaked appearance, which is classical of hyperkalemia. So this patient is suffering from hyperkalemia, which can also describe all the other symptoms which we have told in the patient. For example, the muscle weakness, the palpitations, these also may occur in hyperkalemia. Palpitations may be due to some arrhythmia which occurred. Okay. Now, the next question I asked is, what was the emergency management of this condition, or the emergency or urgent management of hyperkalemia? So these were the findings which we saw on the ECG, and the diagnosis in this patient was hyperkalemia. It's a simple ECG. So what do you do when there is a hyperkalemia? These are the following points. I'm just giving you only the highlights and points. None of the doses are given. For any details regarding the dosage, the appropriate method of administration, etc., please refer to a textbook of medicine, which will help you. You can give IV calcium gluconate is given to reduce the cardiotoxicity of potassium. Insulin and glucose infusion is given to increase the potassium uptake by the cells. Sodium bicarbonate is used to correct the metabolic acidosis intravenous. Nebulization with albuterol or salbutamol is given so that it shifts the potassium into the cells. Intravenous loop diuretics like furosemide are helpful in excreting potassium, but of course it will take a little more time because the excretion is not immediate. The other thing is potassium binders like cation exchange resins and sodium like sodium polystyrene sulfonate, sodium zirconium cyclosilicate can be used orally or given as an retention enema, which can remove potassium. Of course, there is always the possibility of an emergency hemodialysis, which you can do. So friends, I hope you have all answered these questions properly. We'll go on to the next case. Now this is a rhythm strip of lead 2 in a patient. Actually, this is a continuous strip. The top and the bottom panels are continuous. So now my questions are, what is your diagnosis of the arrhythmia? Describe the features which you see in the ECG. Second question will be, what is the difference between the top panel and the bottom panel in the arrhythmia, even though it is the same arrhythmia? What do you think could be the cause of this arrhythmia? Was my third question. And when does this arrhythmia become important, needing urgent treatment? So, what is the cause of the arrhythmia? What is the difference between these two panels? Right? And when does this arrhythmia become important? So you can start off answering the questions one by one. So I gave you a little more time because there are 3 questions which I asked you, right? What is the arrhythmia? What is the difference between the top and bottom page? And what do you think is the cause of this arrhythmia? These 3 questions pertain to what is seen in the ECG. Of course, the 4th one is a clinical question. So we'll go on to the answers. Now, what does this ECG show? It's very simple. Actually, you are seeing multiple ventricular ectopics. These are all ventricular premature complexes or ventricular premature beats. You can see 1, 2, 3, 4, 5. 5 of them in this strip which I have shown here. But the top panel shows these ventricular ectopics are sandwiched between 2 sinus beats, isn't it? This is called an interpolated ventricular ectopic. Whereas when you come to the lower panel, it is not interpolated, but you can see the normal compensatory pause which you see in ventricular ectopics, right? Now, in the top panel, the QRS complexes, if you look very carefully, here, right, here and here, you can see that the QRS complexes are not preceded by P waves. And the RR interval, which I have measured using calipers, is 22 millimeters, which turns out to 78 beats per minute. Whereas when you come to the lower panel, the QRS, the RR interval here, the QRS is a little more closer together, and it works out to 19 millimeters, which I measured. And the upper one was 68 beats per minute, and the lower one turned out to be 78 beats per minute. So there is a difference of 10. So the upper panel and the lower panel, the QRS complexes, that is, which are not the ventricular premature beats, are showing a difference in rate. And in the upper panel, you can see the QRS complexes are not preceded by P waves, which means it is coming from the junction, isn't it? Now, what is the rate? The rate I said is 68 per minute. So, if a junction is beating at 68 per minute, we call it accelerated junctional rhythm, isn't it? So, the upper one shows an accelerated junctional rhythm along with interpolated ventricular premature beats. Now, when you come to the lower panel, what happened? Of course, ventricular ectopics are there, but the rate becomes sinus. You can see the QRS complex is preceded by a P wave. Here there are P waves in front of the QRS complexes, right? And not only the P waves are there, the PR interval is ultra short. You see there is almost no PR segment there, right? So what is that? That is a condition of short PR interval without delta waves. Though it is not WPW syndrome, it is called the Lown-Ganon-Levine syndrome. We have learnt about it in one of our classes, in possibly one of the last classes. Now I asked another question: what is the cause for the this arrhythmia? If you look carefully at these beats, the QRS complexes, the ST segments show a downward slope, as if pulling the T wave downwards. This is a typical inverted tick mark appearance of digoxin effect, and in this patient, because of the multiple ventricular ectopics, we will call it a digoxin toxicity, isn't it? So, all the findings which you see here are multiple ventricular premature beats, interpolated and non-interpolated, accelerated junctional rhythm in the upper strips, and normal sinus rhythm in the lower strip, with a short PR interval and Lown-Ganon-Levine syndrome. So there are multiple diagnoses in this patient. My next question, this is a diagnosis. My next question was, when you will treat this ventricular ectopics in this patient in an urgent manner, that is immediately, without waiting for spontaneous resolution or so. That we will discuss in the next slide. Yeah. Here you can see, when do ventricular premature beats become significant? Now, one, if they are occurring at a rate more than 6 per minute, or that more than 10% of the total heartbeats, that is in 24 hours, is ventricular ectopics. When they occur in bigeminal pattern, of course, definitely the rate numbers will be high. When they are in runs, what is the run of VT? Run of VT is 3 ventricular ectopics occurring in succession at a rate of more than 100 per minute. That is the definition of a ventricular run of ventricular tachycardia. The other thing is when the ventricular ectopic falls on the T wave of the previous QRS complex. This is called RMT phenomenon. We have discussed this point very elaborately, meaning that this can trigger off a ventricular tachycardia or even a ventricular fibrillation and can be fatal for the patient if not treated immediately. When they are polymorphic, that is in the same lead, if you find multiple ventricular ectopics having different morphologies, that means they are arising from different foci. They are polymorphic and they are multifocal. So they shall to be treated immediately. And the other thing is the clinical setting is always important. Is it an acute myocardial infarction with multiple ectopics? It's a cardiomyopathy, or is it a heart failure patient who is getting multiple ectopics? Or is it a myocarditis due to some infection? So the setting is also important. So all these things to be taken in consideration when you are treating a patient with ventricular premature contractions. So we'll go on to our next query. Now this is a 12-lead ECG of a patient who came to the emergency with a history of chest pain of 2 days duration and an occasional feeling of giddiness or near syncope. What is the diagnosis in this 12-lead ECG? What is the possible cause of the near syncope which you will consider? So one is the diagnosis of the 12-lead ECG. The other is what is the cause of this giddiness or near syncope which you have to consider in this patient. That's of course a clinical question. So you can start off answering this question. I'll give you a couple of minutes for this, and hopefully you'll be able to pick up the diagnosis, which is very easy in this case. So friends, I think we can go on to the answer. It's a simple ECG, so I'm sure that all of you would have answered correctly. So what are the findings in the ECG? First, you can see Q waves in lead 2, lead 3 and AVF, isn't it? Simple. And the ST segment shows a coving and the T waves are inverted. The better seen in 3 and AVF, isn't it? So it is an acute inferior wall myocardial infarction. But one other point is look at the QT segment. If you measure the QT interval, not a QT segment, QT interval from beginning of Q to the end of the T wave, it is around 17 millimeter, 17. That is 680 milliseconds. So that is prolonged QT along with an acute inferior wall infarction. So the question will be, what are the causes of syncope this patient could have, right? Any infarction can produce hypotension. So patient could have had a transient hypotension as soon as he had the infarction. That could have caused the syncope, one cause. Also, there could be transient atrioventricular blocks in patients with inferior wall infarction. It could go from second degree block to even a transient complete heart block, which could revert to normal quickly. So that also can produce syncope. The third thing is prolonged QT interval by itself can cause arrhythmias, isn't it? Especially tachyarrhythmias like ventricular tachycardia due to the prolonged QT interval. You know, we have discussed this also in some of our previous ECGs. So all these three causes could be the cause of dizziness or syncope. Of course, there are other minor causes which can produce syncope in any patient with a myocardial infarction, but these are the important causes you should consider in this patient if he gives a history of dizziness or near syncope. Okay, so that was the finding, the Q waves, the prolonged QT interval, and acute infarction with long QT interval, right? So friends, I'm sure that you would have interpreted all this correctly and all these three and answered all the questions alongside. Meanwhile, if you have any suggestions or comments, you may post it at the bottom of this presentation or email your questions to me. I have given the email ID here, and please share these ECGs if possible with your friends, colleagues, and subscribe to my channel if you have not already done so. Thank you and goodbye. I'll meet you in a couple of days with another episode or another session on ECG quiz. Thank you and goodbye.